Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today in this episode number 3, first aid series musculoskeletal system. So today our topic is upper limb and some nerve injuries. So in this video I am going to discuss about some of the anatomy and functions of the nerve and injuries and clinical signs, and we are going to discuss about like axillary nerve, musculocutaneous nerve, median nerve, radial nerve and ulnar nerve. Okay, so step by step we will go, and with images you can appreciate some images and you can learn very deeply. Okay, so first one, in upper extremity nerves, first now we are going to discuss about axillary nerve. If you are seeing this axillary nerve, we can see mostly this nerve is that root value is C5 to C6. Okay, this is branches of posterior cord of the brachial plexus. Posterior is a branches of from the posterior cord of brachial plexus. Okay, how this is coming from C5 C6 and it's a branches from the posterior cord of the brachial plexus, and it's travel through the quadrangular space with the posterior circumflex humeral artery. Okay, so what are where that motor function will be there means it's like deltoid and teres minor. If you are seeing this image, this is the deltoid muscle and teres minor. This is the teres minor. Okay, so these two, that now is innervating to motor functions, that is deltoid and teres minor. So what's the main function? This deltoid, if the deltoid will help for abduction of the shoulder 15 to 90 degrees. Okay, so okay, then what about teres minor? This teres minor will help for external rotation of the shoulder. It's very important of the shoulder. Because why this thing is important? Because if any patient comes with rotatory cuff injury, that time we can check with some special test. So for the special test we have to understand the movements of and motor function of the this axillary nerve, and wherever that axillary nerve is innervating and which muscle, and that muscle function, range of motion, movements, everything we have to know. So that's why in motor this axillary nerve is mostly we can see deltoid and teres minor. So now in sensory mostly we can see the skin over deltoid. If you are seeing this image, you can see this area. In this area we can see three areas of deltoid muscle. So axillary nerve will pass. We can see that is innervation and sensation of sensation of the axillary nerve we can see in this dermatomes and myotomes. Okay, so now injury, mostly if any patient got fracture of the surgical neck of humerus, or if any patient got anterior or posterior dislocation, or because of compresses of axilla. How axillary nerve will get compressed? That axillary nerve will get compressed if any orthopedic cases, like if any patient gone through by surgery, like femoral surgery and tibial surgery and hip arthritis patient surgery, that time that patient have to use crunches. When that crunches, when they are walking, that time they will put their body weight on that underarm with for holding that crunches. So that axillary nerve will get compression. Because why? See here, if you are seeing this image, you can see this is the humerus. From humerus you can see some teres minor, and that axial nerve is coming from below the teres minor muscle. So here when that external force, this crunches, if for example this crunch is compressing in underarm, then it will compress this axillary nerve, so that deltoid area will get numb. So if any patient getting that type of numbness and everything, so we have to think about axillary nerve compression. Okay, so in clinical signs, what are the things you can see in clinical signs means the shoulder will be flattened, shoulder will be flattened, okay, and loss of rounded contour and inability to abduct arm 15 degrees, beyond 15 degrees, and we can see some sensory loss also, and sensory loss over badge area. Why I mentioned badge area means if any police, they will keep here in right and left shoulder, they will keep some badge, so in that area that patient will feel numbness or loss of sensation, or sometimes you can see deltoid atrophy also. Okay, because that part is not getting innervation, so that part is not getting impulses, so what will happen, that nerve will not work, so that muscle will be absence of size, that the size will decrease. Okay, so in special test, what are the things we can do? We have to ask the patient to abduct the arm from 15 to 90 degrees. Why? Because if you are seeing the subscapularis, it will work for till 15 degrees of the abduction. If more than 15 to 19 degrees abduction means the deltoid muscle will take over. Okay, so and we can test for light touch sensation. Okay, light touch sensation over the lateral shoulder. Okay, so this is the X-ray now. So now we are going to see some injury here. If any patient, this is the normal axillary nerve, and this is normal axillary nerve coming from posterior cord of brachial plexus. We already discussed this thing. Okay, so it's originating from C5, C6. Now this axillary nerve is axillary nerve that passing from humerus proximal part, and it's like circumflex we can see here. If any patient got surgery here, that's not surgery, sorry, any patient got have fracture, humeral neck fracture, then the axillary nerve will get tear or injured. Because of the axillary nerve injury, we can see flat shoulder, a loss of arms, deltoid atrophy, and the patient can't able to do abduction 15 to 19 degrees. Okay, and this is shoulder dislocation. Shoulder dislocation also can cause axillary nerve injury. Okay, so next, musculocutaneous nerve. Musculocutaneous nerve, if you are seeing this thing, that root value will be C5 to C7. Okay, and it's mostly arises from the lateral cord of the brachial plexus. If you don't know about brachial plexus, I am going to make this the video about brachial plexus. That time you can watch in first aid series. Okay, so here this from brachial plexus only for upper extremities will get innervation. Okay, so that lateral that root value of, now we are discussing about musculocutaneous nerve. That musculocutaneous nerve is originating from C5 to C7, and from brachial plex we can see lateral cord of brachial plexus, and it's coming, and it will comes from coracobrachialis muscle, and it will go to that median median area of the elbow. Okay, so this musculocutaneous now if you are seeing that motor function, mostly it's innervating to some muscles. That muscles we call biceps brachii, okay, and brachialis and coracobrachialis. It's very easy to remember because musculocutaneous nerve is coming inside the muscle is coracobrachialis and biceps brachii and brachialis. Okay, this is the motor innervation of the musculocutaneous nerve. In action, what are the actions we can see? Yeah, flexion of the elbow and supination. Okay, now sensory innervation of the musculocutaneous nerve is mostly that it will pass the sensation to the lateral forearm. Okay, lateral forearm will get mostly sensation via lateral cutaneous nerve, because this musculocutaneous nerve it will divide into two parts. So that lateral cutaneous nerve mostly that nerve that innervates to the forearm, that forearm part will get that sensation because of lateral cutaneous nerve, branch of musculocutaneous nerve. So now injuries, it's very rare, mostly I never saw this type of case about musculocutaneous nerve, but it's very rare, and it may occur due to penetrating trauma or shoulder dislocation. Okay, you can see this image. In this image where you are feeling this innervation lateral cutaneous nerve of the forearm. So here this is a branch of musculocutaneous nerve, and mostly this nerve if got any injury because of penetrating trauma and shoulder dislocation can cause this musculocutaneous nerve injury. So what are the clinical signs we can see? We can see the patient will in subjective patient will tell like I am getting weakness in elbow flexion. So that patient will get problem with the elbow flexion, and the movement decreased of supination, and we can see some of loss of sensation, over the lateral forearm, sorry. Okay, you can see this image. With this image you can easily find out pathological condition and why. Okay, so now for what are the we have some special tests to find out this nerve injuries. So for musculocutaneous nerve we have to ask patient to flex elbow against resistance. Okay, and we can test for sensation also. We can test for sensation in on lateral forearm. Okay, so these are the things for musculocutaneous nerve. So next we are going to discuss about radial nerve. So this radial nerve is very important because mostly after surgery, if any patient got any like supracondylar humeral fracture, okay, and like any medial side of the surgery, if any patient got means mostly that radial nerve will get stretch because of that surgery, and it will cause neuroplexia or radial nerve palsy. Okay, so it's very important now. So this root value will be C5 to T1, and it arises from the posterior cord. Okay, C5 to T1, it will that's the root value is the C5 to T1, and it's arise from posterior cord. Okay, now if you are seeing this image, in this image mostly that radial nerve will innervate some of the muscles. In that muscles mostly we can see the extensor muscles. Okay, forearm extensors, like extensors muscles of arm and forearm. Okay, what are the muscles mostly this radial nerve is innervating means? Yeah, first one, triceps. In triceps, brachii. This triceps will help for elbow extension. Okay, next, wrist extensors, for wrist extension, and finger extensors. So that patient can do OK sign, that means thumbs up sign. Okay, so in sensory we can see the posterior arm and forearm will get innervation, so that patient will feel the radial nerves, dermatomes we can see in posterior arm and forearm and dorsum of the hand. Okay, especially web space between thumb and index. Okay, this in this area we can see the that is sensory sensation. Okay, I will show you some that hand image. So when that radial nerve injury will happen, mostly mid shaft humeral fracture, mid shaft humerus fracture can cause radial nerve palsy. Okay, and sometimes improper crutches using. If any patient using crutches improperly, then the patient will get this type of radial nerve problem. And yeah, Saturday night palsy also can cause radial nerve palsy. Why? Because when patient Saturday night palsy, why this name came means, if any patient in Saturday, mostly these Americans like Western countries, they will in Saturday they will drink, and they will, when they are sleeping, they will lie on that arm. When they are lying that on arm, that time that now that radial nerve, this mostly very close to bone, because of that our head weight, that nerve will get compression. So we call that is compression in spiral groove. So because of this thing, the patient will get Saturday night palsy. Okay, so in clinical signs, what are the clinical signs we can see means, yeah, wrist drop, that wrist will get drop, and patient will get weak, that grip strength will be weak. Okay, and sensory loss on posterior forearm and hand, sensory loss in posterior forearm and hand. Okay, and we can do some test. We can ask the patient to extend wrist. We can ask the patient for extend the wrist and fingers, and we can check sensation on dorsal web space. Okay, so here, yeah, I am going to tell one mnemonic for radial nerve innervation. Okay, it's very important mnemonic and very easy mnemonic, so you can easily remember. So the mnemonic is BEST. Okay, B means brachioradialis, E means extensors, S means supinator, T means triceps. Okay, so here if you are seeing this image, so you can see here that humerus and that radial nerve is passing here to diaphysis of the humerus. If any patient is lying down, when they are because of that alcohol and because of that too much dizziness, that patient will sleep on this area. Okay, because of that very closely that nerve is passing to the humerus, so they will compress the spiral groove and they will compress that radial nerve, and that patient will feel total numbness. So numbness and tingling sensation. So that condition we call Saturday night palsy or compression of radial nerve. Okay, if any patient getting this deltoid tuberosity or that mid shaft of the fracture of humerus, so then we can think about radial nerve injury. Okay, so these are the things. If in supracondylar fracture happened means, in that time also we have to suspect the radial nerve. If it's like posterior region of the fracture happened means, then we have to think about ulnar nerve. If in proximal part in metaphysis, if any humeral fracture happened means, then we have to think axillary nerve injury. Okay, next. So this is the Saturday night palsy. If patient is sleeping like this on chair, then because of that compression of the spiral groove, it will lead to wrist drop. Okay, whenever you are seeing about wrist drop, then we have to think that is radial nerve palsy. Okay, next. This is the sensation of posterior cutaneous nerve of arm, and here posterior cutaneous of the forearm and dorsal digital nerves. Okay, this is the wrist drop. You can appreciate this image perfectly. Okay, next, median nerve. In this median nerve, mostly we have to this median nerve is very important, and we have to know the root value. That median nerve root value is C5 to T1, and it's coming from brachial plexus, and the brachial plexus formed from both lateral and medial cords. Lateral and medial cords. Okay, so here this is the median nerve coming from below the flexor digitorum superficialis. Okay, so this median nerve mostly we can see medially. And what are the main motor? What are the main motor means? This motor innervation means forearm flexors, forearm flexors and thenar muscles. Okay, in thenar muscles, like we can think about lumbricals and opponents and abductors and flexor pollicis brevis. This muscles we can see in our hand. Okay, so these muscles can innervate by this median nerve. Okay, when it's coming to sensory, in sensory we can see the lateral 3 1/2 fingers on palmar side, and sometimes some part of the dorsal tips of the same fingers. You can see the sensation. Okay, this median nerve is innervating here. So seeing this is the innervation of the median nerve. Okay, so this is the lumbricals here. This lumbricals and thenar muscles. This is the thenar muscles, and some palmar also will get the innervation. Okay, so now injury. How we can that median nerve will get injury means, if any patient got supracondylar fracture of humerus. I am going to make this video for supracondylar fracture of humerus in orthopedic lectures. If you have time, you can watch that video. Okay, and for medial, if any patient got medial nerve injury, then it can leads to carpal tunnel syndrome also. Carpal tunnel syndrome and wrist lacerations. Okay, so what are the clinical signs we can see in median now? Means in clinical signs mostly we have to think about ape hand. If any patient got ape hand, then we have to think about thinner muscles atrophy, and the patient is very inability to do opposite hand, inability to do opposite thumb. Okay, and clinical signs we can see like hand off, benediction, and making fist, and we can check tunnel sign or Phalen's test. Okay, if Phalen's test and tunnel sign is positive, then we have to think that is carpal tunnel syndrome. Okay, if any patient in injuries, if any patient got in elbow, any patient got supracondylar fracture, then hand of benediction, like patient can't flex 1 and 3rd fingers on fist making, that part we called hand of benediction. And in wrist we can see carpal tunnel syndrome because thinner muscles wasting and sensory loss are tunnels and Phalen's signs positive. These are the things we can see in median now. Okay, so this is the sensory part of the median now. In sensory part you can see lateral palm. Okay, lateral part of the palm and lateral 3 by 3, lateral 3 by 3 1 by 2 fingers, like including these fingertips also. Okay, so this median now mostly we can see like one mnemonic, that is loaf mnemonic. L means lumbricals mostly 1 and 2, and O means opponents pollicis. These are the muscles innervating by median now. And A means abductor pollicis brevis. F means flexor pollicis brevis. Okay, so always we have to remember abductor pollicis is not a thinner muscle, because this abductor pollicis is innervated by ulnar nerve. Okay, but mostly here we can see that median nerve is innervating the loaf muscles, that is lateral. L means lateral 2 lubricals and opponents pollicis and abductor pollicis brevis and flexor pollicis brevis. Okay, so this is the median now. Next, if any patient got anterolateral humeral fracture, then that radial nerve get injury, so we have to think about, if anterolateral humeral fracture means we have to think about radial nerve. Okay, if anteromedial means we have to think about medial nerve injury with brachial artery injury also. This about this fractures I already made one video in orthopedic lectures, so we can watch that. If you don't know, then we can watch that videos. Okay, next one, ulnar nerve. If you see this ulnar nerve, that ulnar nerve is coming, that root value is C8 to T1. Okay, so in motor mostly we can see FCU and ulnar half of FDP and intrinsic hand muscles, except loaf means that lubricals. Okay, and abductors and flexor pollicis and longus pollicis, these things, this every muscle we are okay. So here mostly we have to focus on ulnar nerve. In ulnar nerve we can see that flexor carpi ulnaris and ulnar half flexor digitorum profundus, and we can see some intrinsic hand muscles except means lubricals, opponents pollicis and abductor pollicis brevis and flexor pollicis brevis. We are not thinking about that now because it's related to median now. But here for ulnar now we have to think about flexor carpi ulnaris and flexor digitorum profundus and intrinsic hand muscles. Okay, so in sensory we can see medial palm and medial 1.5 fingers. Okay, in injury causes we can see first in elbow. In injury causes first in elbow we can see medial epicondyle fracture. If any patient got medial epicondyle fracture, that means they are very ulnar nerve injury we can see. Okay, next in wrist we can see Guyon's canal compression. Why this compression? Mostly if any patient is doing mostly like cyclist palsy, we can call this thing. Okay, like repetitive movements. If any patient doing repetitive movements, then that patient can get this type of this Guyon's canal compression. Okay, so in clinical signs, first of all we have to see claw hand at rest. Claw hand means that because of that ulnar nerve injury or compression, that hypothenar muscles will get wasting. And sometimes difficulty with finger abduction and adduction because introsi loss. Or we can do some test, that is we can see some sign, that is Froment's sign. The Froment's sign is test for weak adductor pollicis muscle. Okay, so yeah, for ulnar now we have one mnemonic. That mnemonic is POT, P-O-T. P means pinky finger mostly, and O means opposition weak, T means tactile loss in 4/5 fingers. Okay, and for ulnar now we can check with we can do that sensation for that medial palm and medial 1.5 fingers. Okay, and we can check with the pinky finger and these things. Good. So this is the innervation. We can check sensation here. So in sensation I already mentioned the patient, we can see that this medial palm and medial 1.5 fingers, and in movement for this ulnar nerve will mostly help for finger abduction and adduction. If any problem with ulnar nerve, then the patient will get problem with difficulty with finger abduction and adduction. Okay, and we can check some prominent sign also. Okay, so these are the things for this episode 3. So we will meet in our next episode. If you didn't subscribe my channel till now, so if you are seeing this series is valuable for you, so like, share and subscribe. If you have any doubts, you can ask me in comment section. Take care. Bye bye.